Well, welcome to chapter 21. This is a long chapter. There's lots of reading and lots of coding, but I'm going to try to go through it as quickly as I can. Chapter 21 is talking about the reproductive, intersex surgery, female genital system, and maternity care and delivery. We're going to start with the reproductive system procedures. We start on page 570 and go through 590. The code 55920 and reproductive system procedures, there's only one code. This reports the placement of the catheters, needles into the pelvic organs and genitalia for subsequent interstitial radio element application. Think brachytherapy that we just talked about in the last chapter. Read the note in your CPT book after the code 55920 if Heyman capsules are being inserted. The intersex surgery section it talks about codes 55970 and 80. There's only two codes in this subsection. You're going from a male to a female or a female to a male. Complicated procedures are completed over an extended period of time. Think about stage procedures and the modifier that you would use for that, performed by multiple physicians with extensive specialized training. The female genital system, there's an illustration here. There's another illustration also on page 672 in your textbook. It's just showing exactly all of the anatomic elements. And know that there's many bundled services in this section. The female genital section is a subsystem, has many subheadings. The vulva, peritoneum, vagina, can't even talk, vagina, cervix, uteri, corpus uteri, oviduct and ovaries, and in vitro fertilization are the subheadings in this category. Under the vulva, peritoneum, and introitus, the Skene's glands are coated with the urinary system. Remember, we talked about those when we did urinary. All of these things are talking about incision or excision codes, so you need to pay attention to those. What is exactly being done? Under those categories, there's incision, destruction, excision, repair, and endoscopy. The incision categories show the incision and drainage of an abscess in the vulva, the perineal area, or the Bartholin's gland. And here's an illustration that shows part of the vulva is in the code here, and it's showing the cavity when they did what they called marsupialization. A cyst is incised here, it's drained, and then the edges are sutured around the edge to keep that cyst open until it's completely healed. Destruction, lesions are destructed by a bunch of methods, and you remember a variety of methods. You remember that eradication is not excision. If it's destroyed, there is nothing there to excise nor to send for biopsy. Destruction, divided by simple or extensive destruction, so the complexity depends on the physician's judgment. Extensive would be greater physician work, a greater degree of difficulty, or the number of lesions destroyed. This all will be stated in the record and for you to confirm. 56501 through 56515 all have a global period of 10 days on the Medicare fee schedule. So if the patient comes back in 2 days for a recheck, it's included in that payment. You can't charge extra for it. Excision includes biopsies. The biopsy codes all include that local anesthetic, the biopsy itself, and a simple closure. The code is based on the number of lesions, and so you're going to place that number of lesions on your CMS 1500 form in the box 24G. Excision codes 56605 and 06 are designated as separate procedures. You know what that means. If another service code from the female genital subsection is performed at the same section, this would not be billed separately. However, if it's the only thing done, you can build it separately. 56606 is an add-on code with the plus in front of it. You know what that means. It cannot stand alone. It has to be billed with 56605. A vulvodectomy is the surgical removal of a portion of the vulva, and the codes are based on the extent and the size of the area removed. And why are they divided that way? It's telling you how many resources are required to deliver that service and the time that's used to complete it, the normal time. Excision codes, the extent is if it's a simple excision, the skin and the superficial subcutaneous tissues are all removed. If it's a radical, the skin and the deep subcutaneous tissues are removed. So pay attention to that too. The size, so we talk about a partial being less than 80% of the area, or a complete is greater than 80%. The extent and size will be listed on your operative report. Some of these codes include a lymphadenectomy, and some don't, so you need to read very carefully. Code 56640 is a unilateral procedure and has no code to describe bilateral, so if it is bilateral, you're going to use your 50 modifier. Repair codes, there's many plastic repairs. You need to read the notes following the category. If the repair procedure is for a wound, remember, we talked about those in integumentary. So if it's just repairing a wound, that's the system you're going to use to code it. You won't code it here. Endoscopy by means of colposcopy, or with or without a biopsy. So endoscopy of the vulva is divided that way. Then we're into the vagina. The codes are divided based on the service. Is it an excision, incision? Is it a partial or complete excision? Is it a destruction? It can be simple or extensive. So, and there's many codes here. Colpotomy is cutting into the vagina to gain access to the pelvic cavity. Colpocentesis is an incision of the vagina to gain access to the peritoneal cul-de-sac, the area between the uterus and the rectum, to explore it or to drain an abscess. If a colpocentesis is part of a major procedure, it is not coded separately. Introduction includes the vaginal irrigation, insertion of devices, diaphragm, cervical caps, pessonary, etc. You report that device separately. Remember, you're going to use a 99070 or HCPCS code, such as A4261 for a cervical cap. You want to make sure that you're coding those and getting paid for those because they're very, very expensive. So the coverage for the supplies will vary on the payer. Medicare bundles 99070 into its procedure code, and the A4261 is not covered. So code 57180 has a 10-day global period, and you need to pay attention to those too. Okay? And the illustration is there. For repairs that are non-obstetric repairs, this section of this category, we talk about OB-GYN. This is all the GYN section. So for non-obstetric repairs, the global period is usually 90 days, and you need to review that operative report for specific details relevant to the accurate code assignment, especially the approach. Remember, the vaginal approach for repair of a vesico-vaginal fistula, that channel between the bladder and the vagina, 57330. And if you're doing an abdominal approach, it's 51900. So you need to know the approach. Manipulations. There's a dilation. The spectrum is inserted into the vagina and enlarged using the dilator. These procedures are usually always done under general anesthetic or spinal anesthetic because they're so painful and they're not tolerable any other way. A foreign body removal from the vagina without anesthesia, you're going to assign an E&M code. The most hysterical one I think we ever remember having is somebody had a tampon stuck, and I do mean stuck, and so had to come into the office, but we removed it with long forceps, and it was an E&M code. So it's not appropriate to bill a pelvic exam under anesthesia when other related procedures are performed at the same session. For example, if a D&C is performed, that is what you would code. Endoscopy. The endoscopy codes, these are all colposcopies. They're based on the purpose. Why are you doing it? Is this for a biopsy? Is it diagnostic? Is it a loop electrocardial excision procedure? If it's a biopsy, you need to watch for, remember, if it's a biopsy or biopsies, it's the same code. That S in the parentheses threw some of us off last time. So we need to pay attention to that. This also includes any laparoscopic approach for repairing a perivaginal defect. So we need to make sure about that too. The next slide has a great picture that was also in your book on 577 of a colposcopy enabling the physician to view the endocervical polyp that needs to be removed. The next section is on the cervix uteri. So we have an illustration here that was also in your book. It's showing that all of the anatomic features and where you're going to include all of these things. It's the narrow lower end of the uterus. The services include endoscopy, excision, manipulation, and repair. Then the next slide is showing a LEAP or a LETS, a cervical loop, relatively a new office procedure. We used to do them at OB-GYN Associates. The only thing that's horrible is if the power goes out in the middle, and we had that happen once. So that's not a fun thing to be having. Anyway, so this is a procedure that can be done in the office now. It does not have to be done in a surgical suite. It's used to cauterize at the side of the procedure, and it's often a follow-up to an abnormal pap smear or an abnormal examination. Then we have our excision codes. There's conization codes. It's removal of a cone of tissue from the cervix. And also the LEAP technology can be used for this, so which is really quite often. Excision codes in the cervix uteri describe the technique and the approach, as well as the component procedures used in some code descriptions. And then the next section is the corpus uteri. Many complex procedures, and the wording for these, it's so similar in the code descriptions that this is one of the places that you have to read every single word and make sure it's matching, because otherwise you will have the wrong code. The procedures are very complex, and there's multiple variations of some of these procedures, so we want to make sure that we're reading very carefully. The excision codes 58100 through 58294. These are all described on page 579 in your textbook. So a D&C 58120 of the uterus. After dilation, the curette scrapes the uterus. Do not report postpartum hemorrhage services with this code. Those are all going to be in part of your maternity and delivery codes. So this is a whole different procedure, and you need to make sure that you're paying attention whether or not it's obstetric or gynecologic. Your excision codes 58100 through 294. We have many of our hysterectomy codes are here. And again, based on the approach. Is it vaginal or is it abdominal? And what is the extent? Is it just the uterus, or does it include the fallopian tubes? The Quick Check 212 has some great explanation, and it really emphasizes the importance of you need to know what the weight of that uterus was, because that's going to affect your codes. So you need to know the approach, you need to know the extent, and you need to know the weight of the uterus. Excision, these codes are continued. Often secondary procedures are performed with a hysterectomy, but you do not code secondary related minor procedures separately. Those are all separate. Okay, they're all included. Your introduction codes 58300 through 58356. Very common procedures, for example, the insertion of an IUD. The illustration here is also on page 580, and it gives you a really good idea of how this is coded. Again, you need to make sure that you're reporting the supply of the device, not only so that the patient is charged and the insurance gets paid, but it's also an inventory check. You have specialized services here, for example, artificial insemination procedures. And these codes are used to report the physician component of the service. So artificial insemination in vitro, there's different ways to do it. There's also a procedure to test the patency of the fallopian tubes or to open a block tube. So you need to make sure that you're reading all of those things too. So the IUD itself is listed with the 99070 again, or the HCPCS code. Introduction, there's component coding here. We talk about this, there's really good details on 581. Read those full descriptions to identify the approach. This component coding is necessary with the catheter procedures. And the notes following the codes indicate radiology guidance components codes. So you need to know if that component of radiology was it fluoroscopy, or exactly how are they doing that. The technical component is coded from the radiology section. The professional coded component is coded here. So that's what component coding means, is that we need to make sure that you're covering all of those bases and reading all of those notes. Laparoscopy or hysteroscopy, laparoscopic approach for the removal of a uterus or a myoma, and the codes again are divided by tissue and weight. And then here is an example of the laparoscope being inserted through the abdomen on this one. And why would that be preferred? Of course, because it's less invasive than a surgical procedure. Recovery times are shorter, and the risk to the patient is less. And then here we have, this one is going through the uterus. It's the hysteroscopy through the uterus. It's considered a surgical procedure and generally done with a vaginal hysterectomy. So the scopes are placed through the abdomen, through the vagina, to provide that visualization during a vaginal hysterectomy. Okay. The oviduct and the ovary, codes 58600 through 58770. The oviduct is the fallopian tube. The incision category contains tubal ligations. When done during the same hospitalization as a delivery, the ligation is coded separately. Watch, though, be careful of those separate procedure codes. If another unrelated procedure is performed at the same session, they are not billed separately, so you have to really pay attention to those again. Laparoscopy here is based on the purpose. Is it for lesion removal or lysis? Cautionary, if only diagnostic, don't use this system, use the digestive system. Okay, the ovary, there's only two categories, incision or excision. Incision is primarily for the drainage of cysts and abscesses, and they're divided again upon the approach. And the excision is a biopsy, a wedge resection, or an oophorectomy. In vitro fertilization, we talked about this just a little bit ago. Specialized codes used by physicians trained in fertilization procedures. The codes are divided on the type of procedure and the method that is used. Okay, and now we start talking about maternity care and delivery. So this is the OB part of this chapter. It's divided by the services. Antepartum services, amniocentesis, fetal non-stress test, type of delivery, vaginal, C-section, delivery after a C-section, and abortion. Remember that there are OB/GYN providers. It can be a certified nurse midwife, a maternal fetal medicine specialist, a reproductive endocrinology and infertility specialist. The place of service that you may bill this could also be the office, which would be place of service 11, or a hospital setting, 21. Now we also have certified birthing centers. So that place of service would be 24, a facility that specializes in providing a comfortable setting for labor, delivery, postpartum care, and immediate newborn care. When we talk about pregnancy concepts, pregnant women are often referred to by their gravida status, such as G3P2. Gravida means the number of pregnancies. P is for parity, the number of completed pregnancies. So the numbers identify the number of times the patient has been pregnant, which is the G, and the times the patient carried to full term, which is P. So G3P2 was pregnant 3 times and carried to full term twice. So our services here, our antepartum services, we remember that means before. This all starts on page 585 in your textbook. And then there's different kinds of abortion, and we'll talk about those in a few minutes. So there's a spontaneous abortion, which is a miscarriage, a missed abortion, or a septic abortion. So there's many different kinds that now they're divided on based on the method and on the trimester. So you need to pay attention to those notes also. And those are all included in your must reading for sure. There are codes described a global service or portions only, like the delivery only. Sometimes that happens. A woman will start her pregnancy, say, for example, living in Boise, and see one of the OB/GYN docs here, and then get moved across the country, and the delivery will happen somewhere else, and the postpartum care. So you need to really pay attention to what part of the services are being delivered. Gestation. The fetal gestation, approximately 266 days or 40 weeks. There's a great chart on the bottom of page 585 in your textbook. So it assumes that the delivery date to be calculated 280 days from the last menstrual period. If gestation is 266 days, because conception is assumed to occur 14 days after the last menstrual period. The 266 will be the more common thing that you'll worry about. So trimesters, last menstrual period to less than 14 weeks is 0 days. Second one is 14 weeks to 0 days to less than 28 weeks, 0 days. And the third trimester is 28 weeks, 0 days until delivery. So that first trimester is usually the one where we begin to see patients, and then we see them all the way through. The global package is for an uncomplicated maternity case, and it includes all of the care before the birth, the delivery, and after birth, the postpartum care. So we have specific codes for a vaginal birth. It's 59400. Cesarean delivery 59510 and 59610 is a vaginal delivery after a previous cesarean section, and the initials that they use there all the time is VBAC, VBAC, vaginal delivery after a previous cesarean section. And 59618 is a cesarean delivery following an attempted vaginal delivery after a previous cesarean delivery. We would have patients that would have had a C-section and really wanted to try having a vaginal delivery. And our doctors would usually encourage them to try, but just knowing that it may or may not work. So, there were special ways to code those procedures. The antepartum care before birth includes the initial and subsequent H&P, history and physical, blood pressure, weight, routine urinalysis, fetal heart tones, monthly visits to 28 weeks, twice a month visits from 29 to 36 weeks, and weekly visits from week 37 to delivery. And then your antepartum care also included a service. So when you're having services that aren't related to this care, for example, a pregnant female is complaining about a suspicious mole on her left shoulder, the visits to the OB/GYN doctor who's providing that care, he can look at that mole and tell her what it is, but any services regarding that mole is not part of the antepartum care and would be reported separately. The same with patients who would come in oftentimes with things like a bronchitis. We would certainly treat them, but we would have to charge them separately for that. Your delivery includes admission to the hospital, management of an uncomplicated labor, vaginal or cesarean deliveries. You can see all of those notes that are talking all about that. We're going to report things separately, such as fetal scalp blood sampling, external cephalic effusion, and administration of the epidural. On page 586 in your textbook, it has a great bulleted section, and then on 587 in the green box, it gives you all kinds of great information about twins and how complicated all of that is. But it's a great resource on that page. Postpartum care includes hospital and office visits following delivery, exploration of the uterus, episiotomy and repair of the cervical, vaginal, and peritoneal lacerations, placement of a hemostatic pack or agent. Normal follow-up is 6 weeks after delivery. That's a hospital visit, office visit, and they're not reported separately. They're all bundled. Antepartum and fetal invasion services, 59,076. So an amniocentesis, on page of your textbook 587, it talks about the amniocentesis, talks about inserting the needle into the pregnant uterus and withdrawing fluid. Ultrasound guidance is used with this service. Remember, a modifier 26 may be required wherever, depending on where the service is performed and who owns the equipment. And so watch for that, and also watch for component recoding. Again, here we have that radiologic service that might be reported by a different physician. So you need to pay attention to that. Fetal services include stress tests, blood sampling, monitoring, and therapeutic services. And all the OB ultrasound codes are from the radiologic section, 76801 through 76828. Excision codes 59100 through 59160. So here we have postpartum curettage, removes remaining pieces of placenta or clotted blood, or a non-obstructive curettage is 58120, and we had just talked about that in the excision section. Okay, introduction 59200, insertion of a cervical dilator used to prepare the cervix for an abortive procedure or a delivery. It's often called cervical ripening. Those agents may be introduced to prepare the cervix. It softens and opens it. And so we sometimes try to do this to help speed along a delivery if a patient is to the point of her estimated day of delivery and she is not progressing. So the cervical ripening chart is figure 2117, and it uses something called the Bishop scoring system to assess the cervical ripening. And here you can look through the scores of 0, 1, 2, 3, and at what part of dilation it is, what part of effacement it is, what station, consistency, and cervical positioning. The repair codes here are reported only for repairs during pregnancy, not for anything done during the delivery or after the pregnancy. So again, you have to know your timing on that one. routine global obstetrics care. Those are all the codes that we had talked about just a minute ago. They're all listed there. Episiotomies and use of forceps are included in the delivery and not reported separately. The physician provides only a portion of the global care. If it's only for the vaginal delivery, you would code it 59409. Patient has a cesarean and your doctor doesn't do that, or your midwife can't do that, you would report 59514. If it's a vaginal delivery, again, 59612 after a cesarean or after an attempt to have one. So our delivery of our twins, some payers differ on how they want you to report this. Some of them want the modifier 22 for unusual procedural services, and some of them want the modifier 51, which means multiple procedures. So we're delivering one baby, and oh, hello, we have another one. So we're going to deliver that second one. Okay, the abortion services, 59812 through 59857. Spontaneous, happens naturally. Incomplete, requires medical intervention. Missed abortion, the fetus dies naturally during the first or second trimester. The septic is a missed abortion with an infection. The saddest thing ever is when a baby is carried full to term and then dies in the uterus, and we have to deliver that baby. So working at OBGYN, we used to say, was either the happiest place in the world or the saddest place, depending on what was happening. But most of the time, it was the happiest place. The medical intervention can happen. So we have a D&C, dilation and curtilage, or evacuation, amniotic injections, which is a saline, or a vaginal suppository. It depends on, again, what you're using and what approach you're using, how you would code that. So you need to read it carefully. Sometimes if an interamniotic injection or vaginal suppositories fail to induce an abortion, then a hysterotomy may be required. Okay, that's chapter 21. Good luck with all of that. Thank you for your patience and listening to me rattle on.